हेलो यस गुड इवनिंग सर गुड इवनिंग अरे नहीं नहीं नो प्रॉब्लम नो प्रॉब्लम नहीं नहीं सर नो इश्यू नाही काही नाही सर प्लीज ना थोडं ते फॉर्म बी पण आपण घेऊन सगळंच करायचं आहे मला आज जमलं नाही हां ओके ओके रेस्ट ऑफ द फॉर्मॅलिटी हां ओके सर थँक्यू फक्त काही झेरॉक्स एक साईड काढून ठेव hello yes the audio is clear now good evening everyone yes perfect so I'm well all is good so I'm very much looking forward to these live sessions on YouTube because that is how we also learn. So, and we are looking forward to this Predictor series, which is a new initiative by the DAMS. So, to help for the last minute revision, that what are the questions, what are rather the topics expected in the upcoming NEET PG exam, right? So, I'm Dr. Srinath Chandramani. So, today we are going to discuss a little bit about acid-base balance defects. So once you confirm that I'm legible, I'm audible, we can continue further with this very interesting, seemingly tough and rewarding topic. Seemingly tough but rewarding topic, as I mentioned, that there is no bigger reward than a ABG. So when we talk of acid-base balance defects, most of the medical graduates feel that it is a tough one. But we know that it's easy, and every year definitely there is going to be one or two questions related to the acid-base balance defects. So we are going to have an integrated approach. We are going to start with a review of basic physiology. We are going to discuss in detail approach to metabolic acidosis and metabolic alkalosis. That's the topic we are going to study today. Right. So let's get started. Very important topic, acid-base balance defects. So when we start with the physiology, now how is the acid-base balance physiology? We want to know. Just a quick recap. So we have got 45 minutes with us to review this topic, to review the salient features of this topic. We have got 45 minutes. In 1 hour, 45 minutes to 1 hour, we will review this topic completely. So starting with a quick recap of the acid-base balance physiology, we must know that acid-base balance physiology. So an acid-base balance physiology, we must remember that the human body is always pro-acidic. The human body is always pro-acidic is what we say. The human body is always pro-acidic. And why do we say that? Because every living cell in the body needs energy. And energy is in the form of ATP molecules. Needs energy in the form of ATP molecules, and during the ATP production in the cell, the acid is secreted as a byproduct. The acid is also generated as a byproduct in every cell. So you can understand that the human body has a tendency to become acidic. I always say, we tend to become acidic, we tend to become angry and hot. So our body has got a tendency to become acidic, because as long as we are living, every single minute during the ATP production in the cell, the acid is generated in the cell. But in spite of this, if we look at the normal blood pH, what do we find? The normal blood pH is 7.35 to 7.45. That means it is slightly basic. So rather than being acidic, it is actually slightly basic is what we must know. So the acid base in our body is extremely well regulated, that even in spite of having a pro-acidic state, the blood pH is maintained at an alkaline pH. So based on this, we must know what are the mechanisms of acid-base balance. The mechanisms of acid-base balance regulating the pH of the body. Regulating the pH in the body, we must know. So it is just like a story that we have to understand, that the human body is producing the acid, but the acid that is produced needs to be excreted out of the body. For excretion, what are the steps? Number 1, we have got buffering. There is going to be buffering of the acid which is produced in the tissue itself. So at the tissue level itself, there is going to be buffering that occurs. So in the buffering means what is happening? The acid that is generated in the cell is binding to a buffer. The buffers are divided into extracellular and the intracellular buffer. The extracellular and the intracellular buffer. The extracellular, most important, is the bicarbonate. Most important extracellular buffer is the bicarbonate. But read the MCQ carefully. If they ask you the most important intracellular buffer, it is the phosphate which is coming from the bones. It is the phosphate which is coming from the bones which is going to be buffering. Very good. So what happens? The buffer is going to neutralize the acid and transport it to the 2 organs where it is excreted. So number 1, the respiratory mechanism. We have got the respiratory mechanism, which plays a minor role in the acid-base balance, which plays a minor role in the acid-base balance. And we have got the renal mechanism, which is also the most potent, mechanism by acidification of the urine. By the acidification of the urine which occurs at the renal tubule, it is going to play most potent part. So what do the lungs do? The lungs excrete the acid. The lungs excrete the acid in the form of CO2. And that is why we say respiratory defects are there. When there is a defect in the CO2. Respiratory defect is there when there is a defect in the CO2. When the CO2 rises, acid is rising, that will be respiratory acidosis. But when the CO2, I should not use the arrow here also. So respiratory system, when the CO2 increases, you get acidosis. And when you get decrease in the CO2 washout, you get alkalosis. You are going to get, right? Yes, the renal mechanism is going to be by acidification of the urine in the renal tubules. So that is why what we know, the urinary pH is 6.5 to 7.0. It is slightly acidic. Right? So the urine pH is going to neutralize and it is going to remain slightly acidic. It's going to remain. So this acidification is important to us, and here we must know the defect in acidification function. The defect in the acidification function is called as RTA. Function is called as RTA. Renal tubular acidosis is the topic of renal tubular acidosis, we can say. So just we are going to discuss the approach, integrated approach to acid-base balance in our Predictor series. So please remember Parth Patel, नींद आ गई तो सो जाना बेटा, आप दिन भर यही तो कर रहे हो वैसे भी. So point here is what, that we have to review in this AIIMS also. You have seen the questions are very basic. But conceptual topics, and acid base remains an important topic to remember. So we did review of the acid base physiology. The two important defects that we are going to discuss today are the metabolic acidosis and the metabolic alkalosis. So let us look at the metabolic acidosis and the metabolic alkalosis we are going to discuss today. A practical approach, a stepwise approach. So when we look at the metabolic acidosis, metabolic acidosis is defined as the reduction in the plasma bicarbonate level, is defined as the decrease in the serum plasma bicarbonate level. So the defect can be absolute or relative. Absolute means there is really a decrease in the bicarbonate, or relative, that means the acid has increased, making the bicarbonate look low. So we are looking at the metabolic acidosis. Metabolic acidosis is the stages where there is decrease in the plasma bicarbonate. But just knowing that it is metabolic acidosis is not enough to identify the cause of the disease. What are the steps we want to follow? So let us look at this. The steps to identify the probable cause. The steps to identify the probable cause we want to learn here. So important topic, interesting and rewarding. So we want to know steps to identify the probable cause of the metabolic acidosis. So metabolic acidosis is a common acid-base abnormality. How to identify the probable cause of the disease? So the first step is to calculate the plasma anion gap. The first step is to calculate the plasma anion gap. Please remember the formula. It is always only sodium minus the chloride plus the bicarbonate is considered the conventional formula to calculate the plasma anion gap. So the first step you are going to do is to calculate the plasma anion gap. What is the normal anion gap? Normal gap is taken as 10 to 12 milliequivalent. Single best answer is 12 milliequivalent. So the range is 10 to 12, but the best is to choose as 12 milliequivalent is the single best value for plasma anion gap. Based on the anion gap, we will divide the patients into two. Based on the anion gap, we can divide the cases into two, and the approach we want to learn also. If the patient has got a high anion gap acidosis, anion gap more than 12. So patient has high anion gap acidosis, or the patient has got normal anion gap acidosis less than equal to 12 milliequivalent. So we put it as normal anion gap metabolic acidosis. Yes. So best 10 to 12 is the range, but for the formula we always put the anion gap as 12. In the calculation for delta anion gap, we use the anion gap as 12. So 10 to 12 is what we have. 10 to 12 is what we have, is the anion gap. So what we will do if the patient has high anion gap? If the patient has got high anion gap, we must remember in this question. So first we will understand the causes. High anion gap means what? There is increase in one or more of the unmeasured anions. There is increase in one or more of the unmeasured anions. That's how you remember. There is increase in one or more of the unmeasured anions. That is why you get high anion gap metabolic acidosis. Yes, the lecture will be available afterward also. So one or more unmeasured anions is going to be called high anion gap acidosis. So which are the anions? How to remember? Any disease where there is increase in the ketones. So remember, unmeasured anion means increase in the ketone. Diabetic ketoacidosis, starvation ketoacidosis, and the alcoholic ketosis. Alcohol-induced ketosis can cause this problem. Yes, so remember by mechanism rather than memorizing the cause. Very good. Ketones are increased. Increase in the lactates. Lactic acidosis. What are the causes of lactic acidosis? So we know bigonide toxicity. But even in patients of sepsis and shock, when there is switch to anaerobic glycolysis, the patient is going to come with lactic acidosis. Increase in the urates, increase in the phosphates. So remember, very good, increase in the urates in the patients with acute kidney injury and advanced patients of CKD when the patient has GFR less than 25 ml per minute. GFR less than 25 ml per minute. Yes. स्पीड बढ़ाएंगे, डोंट वरी। अरे कहाँ जाना है, यूट्यूब में तो है आप, है ना, कहाँ जा रहे हो। सो सब लोग एक ही पेस में नहीं काम करते ना, आप आराम से देखेंगे। So there is increase in the phosphate level. So you can have again CKD, you can have like rhabdomyolysis. Rhabdomyolysis can cause increase in the phosphate. Increase in the sulfate are related to drug and toxin overdose. Related to drug and toxin overdose can cause the problem. Increase in the sulfate metabolized by the liver. There is drug or toxin overdose. Which are the drugs causing? So there is methanol, there is lithium, there is salicylate, and there is polyethylene glycol. Yes, and there is polyethylene glycol toxicity. Polyethylene glycol toxicity can lead to this problem. Yes. So we are looking at important topics to revise for the NEET PG. These are different initiatives just to achieve our common goal. Common goal is to get the good rank. So it is a stepwise summarized version of how to proceed. So if you get high anion gap acidosis, all you have to look for is the presence of one or more unmeasured anions, and you will get the answer. But if it is a patient of non-gap acidosis, non-gap acidosis is also called hyperchloremic acidosis. Please remember the name. They are also called hyperchloremic acidosis. They are also called the hyperchloremic acidosis. And to identify the cause of a non-gap acidosis, you have to take one more step, and that is to calculate the urinary anion gap. You have to calculate the urinary anion gap also. So you want to calculate here the urinary anion gap. So learning all the formulas is important hai, where to apply which formula. Only when it is non-gap you want to use urinary anion gap. What is it equal to? Urinary sodium plus urinary potassium minus urinary chloride minus the urinary chloride is urinary anion gap. If the urinary anion gap is going to be low, it indicates GI causes. It's going to indicate GI causes indicates small bowel diarrhea or the pancreatic diarrhea. Small bowel diarrhea, pancreatic fistula. So just we have to understand that bicarbonate is secreted from the GI tract, from the pancreas. The pancreas is going to the bicarb is going to be reabsorbed in the small bowel. But if there is a fistula straight to the colon, then the bicarb is lost in the stool. Here the bicarb is lost in the stool. Laxative abuse, colonic transit time is reduced. Bicarb will be lost in the stool. We are going to see this problem. But if the anion gap is high or positive, if the urine gap is high or positive, that is how we diagnose the patient of RTA, renal tubular acidosis. So every subject we are going to cover, this is an integrated approach because we are looking more at nephrology based. In that also acid base remains an important topic. Right, so there is nothing like normal urinary anion gap. We are looking at urinary anion gap around 20 to 25. So different laboratories can have different ranges, 20 to 25. But otherwise, when the urine anion gap is high, you diagnose the patient as having RTA. But don't forget, before we go into RTA diagram, before we make an illustration for RTA diagram, we will take one step forward. That one step forward is that high anion gap metabolic acidosis is the one which is most commonly associated with other defects. Associated with other defects. The most common one which is associated with other defects. So other defects means patient can be associated with the respiratory defects also. So how to identify mixed acid base balance defect? So in a high gap acidosis, it is important to look whether the high gap is alone or whether it is associated with mixed acid base balance defect. Associated with mixed acid base balance defect. The simple way is to look at one of the simple ways. Please remember, this is the trick we can use to identify the mixed acid base balance defect. So in metabolic acidosis, so just remember the dictum. In the metabolic acidosis, yes, delta gap is correct. Delta gap is correct. But here I am going to give you another shortcut. How you can decide? How you can decide in a patient with metabolic acidosis? Remember, the plasma bicarbonate is low. Bicarbonate is low. So there is going to be change in the, there is what is expected. You expect a change in the CO2 also. Change in the CO2 also is expected. So I want you to tell me how to calculate expected CO2. I want you to calculate expected CO2 in a case of metabolic acidosis. How to calculate the expected CO2 in a case of metabolic acidosis? Come on. Delta ratio is correct, but before that I want you to tell me how to calculate expected CO2 in a case with metabolic acidosis. This also we can use to identify. Very good. So we use the Winter's formula. Perfect. So we use the Winter's formula we are going to use. So very good. Winter's formula we are going to use. So what does it say? Winter's formula 1.5 times the bicarbonate value. 1.5 times the bicarbonate value we are going to see. Plus 1.5 times the bicarbonate value plus 8 plus minus 2. So what we are going to use for compensation? We are going to use the formula, Winter's formula. It is 1.5 times into bicarbonate plus 8 plus minus 2 we are going to use. So Shreya and Nandi, what you are giving is the shortcut formula and a hyper even shortcut, but more ideal is 1.5 into bicarbonate plus 8 plus minus 2 we want to calculate. So let's take an example. All of you put it together. If the pH is 7.20, pH is going down, so there is acidosis. Bicarbonate is 15 milliequivalent, also going down in the same direction. So you can say the patient is having metabolic acidosis. The patient is having metabolic acidosis. In this situation, what is the expected CO2? What is the expected CO2 here? 1.5 into 15, 22.5. 22 plus 8 is 30. 30 plus minus 2. So 28 to 32 millimeter of mercury. So what we can do? Calculate expected CO2. Expected CO2 can be calculated. 28 to 32 millimeter of mercury. We can get that. 28 to 32 millimeter of mercury. We can get that. So what we will see in the given ABG, what is the CO2 value in the question, in the ABG? We want to see what is the CO2 value in the ABG or in the question we want to see. So three options are there. One, the ABG CO2 value given in the question is as expected. 30 milliequivalent means as expected. 30 milliequivalent means as expected, or it is less than 30 milliequivalent or it is more than 30 milliequivalent. More than 30 milliequivalent. We are going to get it together again. So what we have to see here, we have to classify what are the possibilities. So just an example, you take it simple, keep a simple point. So if it is going to be 30 as expected, is it going to be more 30 milliequivalent? We want to see here. Or is it going to be more than 30? If it is as expected, you can say it is an isolated metabolic acidosis. It is an isolated metabolic acidosis with compensatory respiratory alkalosis. But the respiratory alkalosis is not a primary defect. Respiratory is not going to be a primary defect. It is an isolated metabolic acidosis, we can say. But if it is less than expected, 30 I am writing, let it be 28. It will be less than expected. Less than expected or more than expected. So patient has metabolic acidosis is there only. Plus what is there? That is what we want to see. So metabolic acidosis is there. Plus what is there is what we want to learn here. Metabolic acidosis plus is what we want to learn in, right? So if it is less, if it is becoming less, so there is an additional disease which is reducing the CO2. Yes, respiratory alkalosis. But if it is more, there is something which is increasing the CO2. There is a respiratory acidosis also. So in a patient with acidosis, it is important for you to check whether the acidosis is alone or whether it is associated with additional respiratory defect. This can be an easy way to identify the presence of mixed acid-base balance defect. It can be an easy way to detect the mixed acid-base balance defect. We can see. So all this is potential MCQ, whether it's a questioning or in the approach format. Let us make our quick chart for the table of RTA. We'll make our quick illustration for the topic of RTA. Yes, renal tubular acidosis is the defect in the acidification. So we'll draw the tubule and mark the points which are commonly asked. So we have got the proximal convoluted tubule. We have got descending loop of Henle, ascending loop of Henle. We have got the DCT and the collecting ducts. Yes, those who have attended the classes feel it is easy, but I am wanting you to only revise the table. Ana likh ke rakha hai is good. Every time let me remind you, when you see the notes and when you think, you feel that yeah, ye to aata hai. But make sure you really aata hai ki nahi. So what we want to know is to review the topic, because these topics are timeless, eternal topics है ये सब, बार बार आते ही रहते हैं, बार बार आते हैं, इसीलिए ये हमें बार बार पढ़ते रहना है. So if we look at it, what are the problems here that we can get? Most important pump, we will put it here in the collecting duct. The most important pump is the present use of H plus K plus ATPase pump. The most important pump in the acidification process is the H plus K plus ATPase pump, which is present in the collecting duct, anatomically in the collecting duct. In the classes, if we have marked in DCT, that is based on the distal nephron. In the collecting duct, the H plus K plus ATPase pump, we have to see H plus K plus ATPase pump, we have to see. So most important pump is this. So defect in this pump, most important pump, leads to the type 1 RTA. or the distal RTA. Type 1 RTA and the distal RTA. So we are going to make a difference. Here we are going to look at. So no Vaibhav, we are going to calculate delta gap in both of them. है ना? In any metabolic, high gap acidosis में delta gap करेंगे. High gap acidosis में delta gap करेंगे Vaibhav. Okay, not in non gap. Non gap में हमको mixed नहीं मिलता. वो high gap के साथ हम delta formula use करते हैं. But in metabolic acidosis in general, we can use Winter's formula to get the answer also. So coming back here, type 1 or distal RTA, what are the points we must write here? It is the most severe form of the disease. It is the most severe form of the disease. It is also the most common inherited type of the RTA. That is why it presents before 10 years of age in a male dominant disease. The most important problem is the severe acidemia. Most important problem is the severe acidemia, which leads the child to develop the short stature and rickets. The short stature and rickets, that is the main problem. But along with the acidemia, child is also prone to nephrocalcinosis. Child is also prone to nephrocalcinosis. Why? Because there is hypercalciuria with hypositrate urea. Hypercalciuria with the hypositrate urea is present. That is why they have additional nephrocalcinosis also as the presenting feature. But what is the diagnostic test? Urine pH. Urine pH remaining more than 5.5 in spite of acidemia is the diagnostic test. Urine pH remaining more than 5.5 in spite of acidemia is the diagnostic test. Right? So what is the treatment? The treatment is only oral bicarbonate and potassium supplementation. Palliative only. Citrate supplementation to reduce the renal calculi. Reduce the renal calculi. We can give citrate supplementation. But it is associated with the worst prognosis. Associated with the worst prognosis. We want to know. Associated with worst prognosis. Chalo, एक trick question. I am putting it here. Most common autoimmune disease associated with type 1 RTA. Give me the answer. Most common autoimmune disease associated with type 1 RTA. Give me the answer here. What is the most common autoimmune disease associated with type 1 RTA? Come on, सोचिए, तब तक मैं second पे जाता हूँ. Second important one is the bicarbonate reabsorption. Very good. Sicca syndrome. Very good. It is the Sicca syndrome or the Sjogren's syndrome associated with type 1 RTA. The second important step is the bicarbonate reabsorption, which occurs in the PCT. If it does not occur, you can get type 2, also called proximal RTA. Type 2, also called proximal RTA, which is literally milder than the type 1. Milder than the type 1. But here, main problem is the defect in nutrient reabsorption. This time question that also. Defect in the nutrient reabsorption is the important problem. What are the nutrients that are absorbed in PCT? Glucose, glycosuria, amino acid urea, and the phosphate urea. Amino acid urea and the phosphate urea are called as the Fanconi's triad. Very good. Are called as the Fanconi's triad. It is called as the Fanconi's triad. We are going to call it. Yes. And there is also vitamin D3. Vitamin D3 activation and reabsorption. Physiology. reabsorption occurs in the PCT, and that is why in type 2 RTA, there is D3 loss in the urine, leading to osteomalacia. But the important point is the bone disease is reversible with D3 therapy. The bone disease is reversible with D3 therapy. That is another question from PGI. The question is what INI-CET we are looking at. D3 supplementation improves the bone disease in type 2, not in type 1. Type 1 will not improve. The least common RTA is the third step defect, bicarbonate regeneration defect. The bicarbonate regeneration defect, which requires the work of enzyme carbonic anhydrase. Defect in that, the type 3 RTA, also known as marble brain disease. We are going to call this because it is the least common type. It is the least common type of RTA. It is due to inherited defect in the CA2 gene defect. Inherited defect in the CA2 gene, but majority present with cerebral calcification. That's why the name marble brain disease. And 30% can also have osteopetrosis, which is marble bone disease also. It is can be associated with marble bone disease also. Marble bone disease also can be present. Yes. So what we have got here, the fourth step, the mildest step of acidification. Is mediated by aldosterone mineralocorticoid. Which activates the epithelial sodium channel, leading to increased sodium reabsorption from the tubule, but it is not free in exchange of H plus and K plus into the urine. H plus and K plus into the urine has to be secreted, because of which if there is a defect in the aldosterone, you end up getting type 4 RTA. In the aldosterone defect. Type 4 is also called hyperkalemic RTA. It is the only RTA with hyperkalemia because defect in both H plus and K plus absorption. It is the most common type in clinical practice, but it is also the mildest form of the disease. Most common clinical feature, asymptomatic. And most common cause is drug induced. And the only treatment is to stop the offending drug. So to stop the offending drug, you get a potential cure, making the prognosis best in RTA. So how is the approach in the metabolic acidosis? How we have to filter out? And a question is common. Metabolic acidosis question aega. 1. ABG based evaluation. Number 2. We identify based on plasma anion gap, whether it is the high gap or normal gap. If it is high gap, you directly get the causes based on whether the defect is in elevated anion, ketone, urate, lactate, phosphate, sulfate. If it is non-gap, you calculate urinary anion gap, which will tell you if it is low, GI cause, if it is high, RTA. And if it is RTA, you evaluate further so that you identify cause of the disease and treat the underlying disease. That's all you have to do. So going to our next fellow, the next one is the metabolic alkalosis approach. We want to know the approach to metabolic alkalosis. The approach to the metabolic alkalosis we want to know. Approach to the metabolic alkalosis we want to know. In metabolic alkalosis, to identify the cause, to identify the probable cause, to identify the probable cause, what steps should you take? Come on. In metabolic acidosis, you calculated the plasma anion gap. But in metabolic alkalosis, what do you want to do? You want to look at urine chloride levels. You want to look at the urine chloride levels. Simple one. You want to look at the urine chloride levels. If the urine chloride levels are going to be low, if the urine chloride levels are going to be low, again it indicates GI causes. ऐसे याद रखना. Low urinary gap in acidosis and low urine chloride in alkalosis indicates GI causes. GI causes में क्या होता है? The HCl is lost from the stomach. The HCl is lost from the stomach and hence they are also called what? Hypochloremic alkalosis. Another name, they are also called hypochloremic alkalosis. They are going to be called hyperchloremic alkalosis. But please remember, there is going to what? So they are going to be also called as fluid responsive. है ना? So the hypochloremic alkalosis is going to occur. What are the causes? What are the causes? How will the HCl be lost from the stomach? When the patient has persistent vomiting. When the patient has persistent vomiting. Yes, due to gastric outlet obstruction. Due to gastric outlet obstruction. Very good. So what will happen due to gastric outlet obstruction? What will the patient have? So in a young patient, pyloric stenosis is most common in the young. But in the elderly, most common is carcinoma stomach. Carcinoma stomach is most common in the old, elderly. It's going to be there. Its elderly is going to be there. So what will happen here? So when the patient has hypochloremic alkalosis, what the body does? Alkalosis is there. So body will try to excrete. Yes, everybody, come on. Vaibhav has put a good question. I'm waiting for all of you कि कब तुम लोग जागोगे? हाँ, कब जागोगे? ये देख के बताना मेरे को. So what will happen when the H plus? What will the body try to do when alkalosis is there in the blood? Body will try to reduce the acid excretion. Vaibhav, body will try to reduce the acid excretion. When there is alkalosis, what will the kidney do? Kidney reduce H plus excretion so that it can compensate, and urine chloride is proportional to H plus. That is why it is also low. Urine chloride is reduced because H plus is reduced. Persistent vomiting, Ryle's tube aspiration, antacid abuse. Ryle's tube aspiration, antacid abuse. Come on, yes, can cause hypochloremic alkalosis. But on the other side, if the urine chloride remains high, that means defect is in the kidney. Renal causes. Renal causes which are mediated by aldosterone excess state. They are mediated by aldosterone excess state, and that is why they are called as hypokalemic alkalosis. They are called as hypokalemic alkalosis. We have to remember hypokalemic alkalosis. They are going to be called as. Hypokalemic alkalosis, they are going to be called as. So hypokalemic alkalosis, what is most common cause? Most common cause is adrenal disorder, endocrine. Most common is adrenal gland disorder, primary adrenal disease. Which are they? Conn's syndrome, Cushing's syndrome. Conn's syndrome, Cushing's syndrome. Number 2 is drug-induced chronic drug use. Which chronic drug use can cause the hypokalemic alkalosis? Which chronic drug use can cause? The chronic use of loop diuretics, the thiazides and the steroids. Just like Cushing's, the loop diuretics, thiazides and the steroids can cause the risk of hypokalemic alkalosis. Hypokalemic alkalosis. So what is the diagnosis of exclusion in this group? What is the diagnosis of exclusion in this group? The topic we want to enhance a little further, the inherited channelopathies. The inherited channelopathies of the renal tubule. We want to discuss a little more. Inherited channelopathies, we want to discuss a little more. So let us take it forward. Inherited channelopathy का एक column, and then we will close it with a comparison between acidosis and alkalosis. Which is better? ये end में close करेंगे after we make the chart for inherited channelopathies. We make the chart for the inherited channelopathies. So inherited channelopathies are a group of inherited disorders. Inherited disorders. Draw with me. So draw with me. We have got again the tubule PCT. We have got the DCT. We have the loop of Henle, DCT and the collecting ducts. So draw with me once again. So what we have got here? We have got the PCT. We have got the loop of Henle. We have got the DCT and the collecting ducts. We are going to draw it again. So nephron representation again we will draw. But in this case, the most dreaded, most serious is the red cross in the ascending loop of Henle. Red cross in the ascending loop of Henle. Barter's syndrome. Ascending loop of Henle is the Barter's syndrome. What it is? Barter's syndrome, autosomal recessive inhibitory defect of sodium potassium 2 chloride ATPase pump. Autosomal recessive inhibitory defect of sodium potassium 2 chloride ATPase pump. That is why chronic loop diuretic use can mimic Barter's syndrome. So we are writing the drug mimics. The chronic diuretic use looks like Barter's syndrome. But remember, 30% of Barter's also have deafness. MCQ. Which is the tubular disease associated with deafness? पूछते. Which is the tubular disease associated with deafness? They are going to ask you. Tubular disease associated with deafness. They are going to ask you. Because glomerular disease is Alport's syndrome. So why? Because the same pump also regulates, maintains the endolymph concentration in the cochlea. Endolymph concentration in the cochlea. The same pump is working. So MCQ में the common tubular defect causing deafness, tubular defect causing illness, glomerulonephritis plus deafness. Please remember, glomerulonephritis plus deafness, we think of Alport's syndrome. Glomerulonephritis plus deafness, we think of Alport's syndrome. But tubular defect, with deafness is the Barter's syndrome. Tubular defect with deafness is Barter's syndrome. Very good. Very good. That's what we must know. Correct. The second one is the blue cross in the DCT. We have got Gentleman's syndrome. We have got Gentleman's syndrome. Gentleman's syndrome is what? Autosomal recessive inhibitory defect. Autosomal recessive inhibitory defect of the sodium chloride co-transporter. Sodium chloride co-transporter is going to be there. So what will it cause? It will cause metabolic alkalosis will occur. So it is a milder form. It is milder than the Barter's. It is milder than Barter's, but causes metabolic alkalosis like Barter's. So which drug will do? Chronic thiazide use. Chronic thiazide use can mimic Gentleman's syndrome. But always remember, the third is the important odd man out is the Jordan's syndrome. Is the Jordan's syndrome is odd man out. Jordan's syndrome is autosomal dominant stimulatory defect. Autosomal dominant stimulatory defect of sodium chloride co-transporter. It is opposite of Gentleman's. So I am making it here opposite of Gentleman's. So this is a purple plus opposite of Gentleman's. Autosomal dominant stimulatory defect of sodium chloride co-transporter. That is why it's the only channelopathy which presents with hyperkalemic. It presents with hyperkalemic acidosis, which looks like type 4 RTA. And we just studied type 4 RTA is a aldosterone defect. So problem resembles aldosterone defect. Resembles a aldosterone defect. But there is no defect in the hormone. Defect is in the receptor. Hence it is called pseudo hypoaldosteronism. But defect is in the receptor, not in the hormone. Hence it is called as pseudo hypoaldosteronism. Pseudo hypoaldosteronism. It's going to be called as pseudo hypoaldosteronism. No hypertension, Dr. TJ. No hypertension in Jordan. Hypertension is in Liddle's syndrome. यहाँ पर हाइपोटेंशन है, हाइपो, बिकॉज एल्डोस्टेरॉन कम है, एल्डोस्टेरॉन कम है. There will be no hypertension for sure. Normotensive, pseudo hypoaldosteronism. And here the drug of choice is thiazide. The drug of choice is thiazide use is the drug of choice. In both Gentleman's and Jordan's, BP remains normal BP because the defect is mild. The defect is mild. It's going to remain mild. But what you are thinking about is the Liddle's syndrome, green plus. That is the Liddle's syndrome in the DCT. Liddle's syndrome is autosomal dominant stimulatory ENaC defect. Autosomal dominant stimulatory ENaC defect. So it mimics, resembles aldosterone excess state. It resembles aldosterone excess state. But actually there is no aldosterone. It looks like aldosterone excess state. Hence we call it as pseudo hyperaldosteronism. We call it the pseudo hyperaldosteronism. Yes, it can present as incidental hypertension, asymptomatic hypertension in a young before 30 years of age. It looks like incidental hypertension before 30 years of age, and the drug of choice is amiloride. The drug of choice is amiloride. ENaC antagonist offers potential cure. Offers potential cure, but the use of exogenous steroid can mimic the Liddle's syndrome. Exogenous steroid can mimic Liddle's syndrome. Remember the dictum. Why does it happen like that? When very high levels of glucocorticoids, very high level of glucocorticoid can exert action on mineralocorticoid receptor. Exert action on mineralocorticoid receptor, that is ENaC. Receptor, that is ENaC, we can say, and that is why they look like Liddle's syndrome. So now you can understand why the steroid toxicity, why does steroid cause edema, why does steroid cause hypertension. You will get to know. This is an extension to the rule. If I ask you how to differentiate one of the important differences, this can lead to hypokalemic alkalosis. Lead to hypokalemic alkalosis can occur. Hypokalemic alkalosis can occur. But what is the extension in endocrine? How to differentiate between Cushing's disease. It helps to differentiate Cushing's disease versus Cushing's syndrome. Ectopic ACTH production. Ectopic ACTH production. It helps to differentiate the causes of Cushing's disease. You will understand how it will be differentiated. Cushing's disease is pituitary adenoma leading to hyper ACTH, but it is a benign state. Hence, ACTH levels are elevated, but relatively milder. Hence, glucocorticoid levels are elevated, but relatively milder. Not enough to exert action on ENaC. Not enough to exert the action on ENaC, and that is why what you say, hypokalemic alkalosis is absent in Cushing's disease. Hypokalemic alkalosis is absent in Cushing's disease. So not enough to exert action on ENaC. But in ACTH production, this is a paraneoplastic syndrome. This is paraneoplastic syndrome, which is autonomous, leading to very, very high ACTH levels and very high glucocorticoid levels also. And hence, it can exert action on ENaC. Exert action on the ENaC, leading to the hypokalemic alkalosis as well as myopathy. So we say clinical difference, how to differentiate between Cushing's disease and ectopic ACTH production. Cushing's disease and ectopic ACTH production, this is the connection. The physiology connect is this, that there is a very high levels of glucocorticoid can exert action on mineralocorticoid receptor. We can say mineralocorticoid receptor, we can say. That is how the action can occur. So this is our understanding. Okay, very good. This is our understanding of the Cushing's and the channelopathy. So to summarize this session, I am going to ask you to differentiate between metabolic acidosis and metabolic alkalosis. Tell me which one is better to have. I want you to differentiate between metabolic acidosis and the metabolic alkalosis. Metabolic acidosis and metabolic alkalosis. I want you to differentiate so that I can summarize the points of this session in a comparative manner. Very important. Ana? So metabolic acidosis versus metabolic alkalosis we want to know. Metabolic acidosis versus metabolic alkalosis. Primary defect is in the plasma, bicarbonate. What is the presentation? What is the early presentation? What is the early presentation of metabolic acidosis? Come on. Of course, Rashti, you can differentiate by DEXA suppression also. This is one of the clinical differences. Clinical differences लिखते ना, DEXA suppression is also going to be not 100%, but clinical difference I am trying to differentiate. So tell me, what will be the presentation? Each one of them, you help me differentiate. Metabolic acidosis में हम क्या लिखते हैं? Metabolic acidosis, plasma bicarbonate is low. This is the more famous disease, no? Everybody knows about metabolic acidosis. Metabolic acidosis is the famous disease. Everybody keeps an eye. ICU में बोलते हैं एसिडोसिस पे ध्यान रखो, एसिडोसिस पे ध्यान रखो. Plasma bicarbonate is low. But what is the early presentation of acidosis? They present with Kussmaul's breathing. They present with Kussmaul's breathing. They present early. Please remember, rapid labored breathing. But what is it due to? It is due to the respiratory compensation. It is due to the respiratory compensation. Patient presents early to the doctor. Patient presents early to the doctor. Patient presents early to the doctor. That is why early presentation in metabolic acidosis. And once the diagnosis is done, we want to look at palliative treatment. Do we have any palliative treatment? Do we have temporary treatment to identify the problem? Yes, we can give IV soda bicarbonate, can be given as a temporary measure, and that is why the prognosis is relatively better, is relatively more favorable, Please remember, that's why I always say metabolic acidosis क्या है? Famous है. People are well aware, but relatively less mortality. Relatively less mortality occurs due to metabolic acidosis because the patient comes early, treatment is available, hence the outcome is better because awareness is also normal. But metabolic alkalosis में problem क्या होता है? Yes, metabolic alkalosis, bicarbonate is more, but early presentation remains asymptomatic till late stages of the disease. Because here, what will the respiratory compensation cause? Respiratory compensation depresses the breathing. Depressed, shallow breathing does not cause the symptom. Rather, patients become drowsy. And it goes unnoticed. Additionally, in the ICU, use of sedatives can further worsen the respiratory component. So, palliative treatment not available. Please don't inject HCl now. So, क्या हो जाता है? Late presentation with no palliative treatment makes the prognosis poor. Leading to common cause of mortality in the ICU. Remember that. So always I tell my students, in the residents especially, that what we think is famous may not be dangerous, but what we don't think of may be dangerous. What we don't think of is dangerous. And that is why I want you to focus. I want you to read the question carefully. Do not be afraid of acid-base balance disease. because in the ABG class you have covered well how to interpret the ABG. And I hope in today's session we have identified the basic differences between the metabolic acidosis approach versus the approach of metabolic alkalosis with an overview of RTA and channelopathies. So hope you all benefited. All the best, Anna. Thank you very much. And we will see you last on 31st August. Again we will see and we will find out what more important topic to do. Follow the Predictor series. Once you revise these are high yield topics, and hope we hit home well. Chalo, we hit Olympic gold. Chaliye, bye bye.